Okay, everybody, let's get started. Welcome to today's webinar on the recent updates and changes related to COVID-19 billing and coding. My name is Tori Kinlick, and I am the Marketing Director here at VitalWare. As always, we appreciate you taking time out of your busy schedules to join us. So before we dive in, just a few housekeeping items for those new to our webinars. All attendees are on mute in order to eliminate background noise for our presenter. But we do encourage you to interact with our speaker using the Q&A panel, which can be found at the bottom menu bar on your screen, not the chat panel. Please use the Q&A panel. We will be monitoring that one and trying to address all the questions that we have time for following the presentation, and that we will also be looking to address anything that we don't have time for once the presentation wraps up today. The presentation is being recorded, and we will share the link of the recording with all attendees later on today. And following the event, we will send everyone that has attended information on where to find the recording, a copy of the presenter's deck, and how to download your CEU certificate. Now, on to the good stuff. Our presenter today is Ardith Campbell, the Manager of Product Content here at VitalWare. Ardith is a certified outpatient coder and certified professional coder through the American Academy of Professional Coders, AAPC. She has over 30 years experience in the healthcare industry with a focus on reimbursement, coding, and regulatory compliance. Ardith is responsible for updating and maintaining the codes and other content in our VitalWare products. So with that, Ardith, I will pass it over to you.
All right, thank you. And well, good morning or good afternoon, everybody, depending on where you are in the country. And first and foremost, we've got our infamous disclaimer statement that this information is current as of today. And of course, you know, tomorrow that can change. Let's see. Now, what we're going to cover is we'll touch base on some of the ICD-10 PCS codes that were effective August 20th, and then any current procedural terminology updates or Hicks code updates. We'll kind of touch base on the evaluation and management versus the originating site fee. We still get some questions on that. And we're also going to discuss modifier CS, and which is the cost sharing modifier, and the associated CPT and Hicks codes that go along with those. We'll go into the pre-admission COVID-19 testing and some new ICD-10 diagnosis code updates, plus some possible new diagnosis codes that may become effective January 1st, 2021. And in case you did not know it, the public health emergency declaration that was set to expire on October 23rd has been renewed for another at least 90 days. By law, it has to be reviewed every 90 days. And so doing the Google date calculator, that puts it to expire January 21st of 2021. So that at least gives you the opportunity for those waivers and flexibilities to at least get us through this flu season. All right, the National Pessimist Society, your blood type is B negative. I thought that was kind of a little funny. Okay, so we did discuss the new PCS codes. These did become effective August 1st. I just kind of like to touch base on them because they're different start dates than the October 1st annual start date that we're used to. So this gave you the PCS codes for administration of items like your remdesivir, the okay, I'm going to give up on that one, sorry. And whether it's the peripheral vein or into your central vein. And then this also gives you the administration codes for your, here we go, the convalescent plasma. So those last two codes on this third slide. And there is no PCS, or there is no Hicks code for convalescent plasma. And during the CMS office hours call, it was kind of brought to CMS's attention that, when things are able to be done on an outpatient basis, they will need a mechanism. You'll need a mechanism to report the convalescent plasma on the outpatient side. They didn't mention anything other than, well, it is a biologic, kind of winking that you might be able to use one of those unlisted biologic codes, but there hasn't been any guidance out on that yet. But on the inpatient side, you do have the ability now to identify that you are doing a transfusion of convalescent plasma, and then the plasma itself would be used, reported with the revenue codes for blood. All right. Now, in the MLR and Matters article, the SC 20015, CMS did state that for admissions effective September 20th, those claims that are eligible for the 20% increase in the MSDRG weighting will have to have a positive COVID-19 lab test documented in the patient's medical record, and that it can be imported into the medical records, and that viral test has to be done within the 14 days of the admission. But it, and on the off chance that it's not done at your facility, you can import that into the medical record. Other tidbits in that article state that if the test was more than 14 days ago, that CMS will consider whether there are other complex factors in with that. But if the patient has a COVID-19 diagnosis, but you do not have that positive test result, you can decline that additional payment when the claim is submitted. In the initial posting, when they posted that, they just said that the instructions on how to do that would be forthcoming. And so they have forthcome with that information. And so you just enter a billing note, NTE02, the no positive test. But it has been brought up to CMS in the office hours calls that sometimes the patient has no documentation that they're positive because they went and got the test and they either got a text or a phone call that says that, they were positive or negative, and patients can't remember, or they don't remember, or they don't know who actually did the test for them. So trying to chase down that test result is problematic. So CMS is aware that that can be an issue, but there has not been any instructions on how to remedy that situation. So unfortunately, that's still kind of floating out there as on their to-do list. All right, now, yesterday was a busy day because the AMA released some new CPT codes for the lab. We've got the 87636 and the 87637. So those are your infectious agent detection by nucleic acid. And so you've got where this is checking for the COVID-19 and influenza types A and B. And then the 87637 is checking for COVID-19, influenza A and B, and RSV, because I have a very difficult time trying to pronounce the respiratory syncytial virus. And then they also have the immunoassay with direct optical or visual observation for COVID-19. And I've given you the parent codes that go along with those. Now, along with this, they also have PLA codes available. The manufacturer did get an emergency use authorization. And so you've got, again, the PLA codes. And so this one is the 0240U is looking for the excuse me, COVID-19 and influenza A and B. And then the 241 is looking for the COVID-19, the A and B, and RSV as well. All right, and then with some of the, with these changes, they also updated the microbiology guidelines, and there's, because with the updates, there were the 5 new codes that we just covered, and then there were 40 revisions and 1 code was deleted. And so what they did was they were taking a look at 3 different areas. So they discussed single step versus multiple step methodology, the immunofluorescence, and then direct optical observation. So the single step versus multiple step methodology for the immunoassays is characterized by the amount of manipulation required by the laboratory technologist. So if little manipulation is required, that's considered your single step. And an example of that is like your rapid strep, where they take the swab, you put it in a little container and crunch it, and 5 minutes later you can see the results. So that would be a single step. And then if multiple touch points are required, then it's considered a multiple step process. And with the increase of automation and also the processes within the machines allowing multiple processes to occur within the analysis and testing equipment, it's kind of lessened the utility of characterizing those into a single step or multi-step category. And so at this time, even though only the immunoassay or the immunology codes were revised, they are going to take a look and broaden that farther out. And so they also, within the CPT Assistant, the special edition article that they publish along with that, and I've got the link for that in the references. They said that, that immunofluorescence is a procedure that is to detect antigens in cellular contexts, and those using antibodies and tagged fluorescent markers. And the important part of that is that the fluorescence is identified using a microscope. So the CPT editorial panel determined that, the non-microscopic immunofluorescent techniques really do not need to be included in that family. So the code range, for the 87301 through the 87430 were revised to include the phrase fluorescence immunoassay and removed the reference to a multi-step method. And then for the direct optical observation, that's where you can get your qualitative result by producing some type of a signal or a reaction chamber that can be interpreted visually. And so, and the editorial panel said that, this right now is only going to apply to the infectious disease codes and not drug testing codes. So that's going to be, that's kind of a different topic for a different day. So when the direct optical observation codes were created, the understanding was that those immunoassays were more along the lines of the single step methods and were a lot of your point of care testing codes. So they've updated those codes, this 87802 to 87899, to include the phrase IE visual. So that caused CPT code 87450 to no longer be necessary. So it is going to be deactivated. And then they've updated the CPT parenthetical note under 87450 to add, you can either take a look at your immunoassay technique or your direct optical visualization technique. All right. And so this, the 87301 is a parent code. And so they have updated the description. This is the old description, but what they did, let me see if I can get the annotate here. Is that they did go ahead and remove this and change the verbiage to be immunofluorescence in here. So just a little bit of an update, but it does then have a tumble down effect so that it will affect this whole range of codes. So that's kind of why there's a whole bunch of other updates. And so within the 87802, which is also a parent code, they added the IE visual, and so then it just so there is a trickle down effect. All right, so and so what that does though is that well, the CPT books are already published for the year, and so that means that these will not appear until the 2022 manual is available. And just kind of as a heads up, the next PLA meeting is to occur right around the 28th. The AMA website says on or around the 28th. And then the CPT editorial panel meeting after that is on or around November 5th. So if there are more codes to come out, they should be right around that time frame. So just a heads up to kind of keep your eyes peeled around that time, because then, right after that, they should start publishing their, the annual codes are out, but they'll start publishing information on the 2021 changes. All right. Okay. I thought I did. Okay. All right. So what they did was they updated some of their guidelines, and so they made things more clear for you. So when you're taking a look on primary source specimens, microscopically, so they tell you to go to those immunofluorescent assay codes and give you the code range. And then if you're doing them by direct visualization, then you can see, or what they're calling the non-microscopic, then that's the 87301 codes there. And so then they also give you the, well, I got that a little backwards, but they also give you the direct visualization, the 87802 range of codes. And then if this is for a primary source, means that you took the swab or the sample right then, and it's not a culture. So if you are doing something similar to a culture, then it refers you also to the code range. So it's nice that they came in and broadened the guidelines as well. All right, so there were also some codes that came out September 8th. So they have been out there a little bit. They have the 86413, which is for a COVID-19 antibody. And so this one was created because other antibody tests were either qualitative or semi-quantitative, and this one is specific for quantitative. And the AMA said that this one is really they needed this because it's going to help assist with epidemiology and pathogenesis, and hopefully prevention and treatment. And that's also when they came out with the 99072 code for your additional supplies and materials when performed during a public health emergency. And this is to help capture additional clinical staff time. That also includes your 3 surgical masks and your cleaning supplies. Medicare is not covering this at this time. For facilities, it has the status indicator of B, which means it's not reportable and it's not payable under OPPS. And on the physician side, it's also got a bundled procedure code or status code. All right. Whew. So we do still get some questions regarding the evaluation and management service, or your E&M versus the originating site fee. We do have a lot of information regarding this on our COVID resource site. So if you go to our vitalware.com under resources, we do have a page that's got the FAQs and our recordings from our previous webinars available for you. And we also have a lot of these questions in My Advisor. If you have access to that, you can search it. So for the evaluation and management and the originating site fee, for part of this, you kind of have to think that, a good way to think of it is that CMS had to do some really good gymnastics to work around the regulations, the laws that are in place for the originating site fee. So some of it is, you're going, well, why in the world did they do that? Well, it's because, with the regulations in place, how could they get around them so that you can get some reimbursement? So in the CMS COVID FAQs, which I have linked also in the resources, they have a decision tree, which is really helpful in determining, okay, can I bill an evaluation and management code, or your like your G0463, which is your like your clinic visit. It also works for whether you're having an emergency department visit, just kind of an evaluation and management site visit. All right, so is there a distant site practitioner who is billing for services on the list of telehealth services? And are they using modifier 95? And if that is yes, okay, if the patient is registered as a hospital outpatient and the hospital staff is just basically doing supportive services, then you can bill the Q3014. So what this can be used for is if the physician is in their home, or they could, well, as long as they're someplace within the United States or territories, they could be providing telehealth services. And if the hospital has that patient registered, well, has the patient home registered as an offsite or remote provider-based apartment, then you can bill the Q3014. All right, so then the next kind of thought process is, can the hospital service be furnished remotely to a patient in an off-campus provider-based apartment? All right, so if the answer is yes, then the hospital staff can furnish a remote hospital service using audio-video technology. You can bill the care as if it was furnished in the hospital. And so for that, the patient's home needs to be designated as an off-campus provider-based apartment. All right, so, and if the answer to that is no, so if you send staff to the patient's home, then you can bill it as if the care was furnished in the hospital. And that's all predicated on the premise that that patient's home has to be designated as a provider-based apartment. All right, so how do you make the patient's home a relocated provider-based apartment? So this is the information that you need to send to your regional office, and it can be sent by email, and it would have to be encrypted within 120 days of the provision of the service. And you do not have to send them, onesies, twosies. You can have, whole Excel spreadsheet or, other medium to send that information. And that is because the patient's home is not considered an originating site by law. So kind of that wiggle room or those gymnastics is to allow you to have that patient's home be designated as a provider-based department. Now, listening to the CMS office hours calls, they were kind of, somebody asked, well, are you going to be checking all of these? And they were kind of broadly hinting that, they would probably only spot check. So I don't know that they're going to absolutely check each and every one. But it might be if they're trying to uncover something. All right. If laughter was the best medicine, but then I came down with this infectious laugh, har har. Really good dad joke, I guess. All right, so let's talk about some of the modifier CS updates. So CMS did provide a list of codes appropriate for using the modifier CS cost sharing. So there's the definition of the modifier. They have separate lists for different providers that they presented in the special edition 20011 article. And so I've got the link to those lists in the references for you. So there's a list for professional services, ops and non-ops, outpatient prospective payment system providers. For critical access hospitals, they're supposed to use either the professional or the facility lists as appropriate. And then there's another list for the rural health clinics and federally qualified healthcare centers. And the codes on those lists vary. Now, the integrated outpatient code editor has a very large list of those services. They did add a return to provider edit to look for the CS modifier that's on a code that is not on the list of codes that they've published where they're appropriate. So they have, it's edit 114, it's item or service not allowed with modifier CS, and it is retroactively effective to March 18th, 2020. So yes, they published that one just the other day. So I don't know if they're going to go back and be looking for those. Just want you to take a look, and I've got a partial list here of those codes. So these are codes that are appropriate for using that CS modifier. So you've got your clinic visit, your G0463. The C9803 is your specimen collection. So we've got observation services there for the facility. You've got your type A and B emergency department visit, critical care nursing facility. So basically it's the evaluation and management or the evaluation and assessment codes. But it did not list anything like any lab services, no x-rays, nothing. They were pretty much all evaluation and management codes. So when the question, there were previous questions, hey, if they come in and they're evaluated and we need to have chest x-rays to see if there's any infiltrate, does that get the cost sharing waived? Well, this is a big resounding no. And the list was really too large to put everything on the slide here. So I just wanted to give you a good example of those. And then just to point out the 98970 through 72 and the 99421 through the 99423, those are the online evaluation and assessment codes. Sorry, got a frog in my throat. All right, so the evaluation and management or assessment does not necessarily need to be in person. It can be through audio video meets. All right, we still have been getting a couple of questions on the physical therapy and some of the billing for those. So we've got, for this example is for professional services. So for claims that are going to be submitted on the 1500, use the modifier 95, and then the place of service that describes the location where the therapist normally furnishes care. Now for facility side, you have two options. And so for billing for outpatient therapy performed by hospital employees. So you need to first determine whether or not you're going to be providing telehealth services. So if the hospital employee is going to be providing telehealth services, those services have to be on the CMS telehealth list. You would use not modifier 95 on each telehealth service. And, you know, facility claim forms have no place of service field locator, so you're not going to have to worry about that. But you're not able to submit for the originating site fee because the patient's home is not designated as a provider-based department. So there is that. You don't have to go through the rigmarole of sending the list to the regional office, but you are subject to furnishing only those services that are on the telehealth list. All right, now the second one, the second option is where the patient's home is designated as a provider-based department. So you are not limited to the services that are on the telehealth list, and you do not need to use modifier 95, which is the telehealth service, but you will need to use the modifier, the PN or the PO, designating whether it's the non-accepted provider-based department or an accepted provider-based department. All right, now your specimen collection charges, if the physician is having an office visit on that day, then the E&M, the evaluation and management, includes obtaining the specimen. If there's no office visit, then you can bill that level 1 evaluation and management. And then for the hospital, you do have the C9803. And at first, CMS was saying, don't report it if you are doing an evaluation or other service. But then they did come back later and say that it can be reported with other services. But it does have the Q3 status indicator, which means it will be packaged into other services if there are other major services provided on the same day. All right, so pre-admission testing, that's kind of a big one. And I have a frog in my throat, I'm sorry. So for pre-admission testing, it is going to be packaged into the DRG if it's when you're within your 3-day or your 1-day payment window. And then your outpatient admission, it will package when there's that other STV status indicator service on the same day. So that's including your major procedures and clinic visits. All right. So specific to the modifier CS cost sharing, the guidance, what about after the, they're not getting tested because they think that they're sick, they're getting tested because they are going to have a procedure done. Then what CMS has said is that during the public health emergency, the modifier can be reported with can be separately reported with codes that are going to result in an order for the administration of the test. And so basically, if they're evaluating the patient to see if they need to have the test, to see if they're sick, then you can use the CS. Otherwise, if it's a procedure, normally it would not be, you would not need to use it. All right, so the diagnosis guideline changes. And so this is where they have taken out the presumptive positive COVID-19 test. And the reason why they're removing this is that it used to be, I kind of think back in the, was February or March, the olden days, that where the tests had to be sent to the CDC for the yes or no on the COVID-19 diagnosis, and that's no longer required. So they are removing that requirement. So now it is only used for a confirmed diagnosis. All right, so for exposure to COVID-19, if you have somebody that's asymptomatic, you can code the Z20828 codes. And then for anyone that has symptoms or exposure, you can, but basically you can also, if they have confirmed, you would diagnose it confirmed. So they're kind of normalizing the usage of the symptomatic and asymptomatic and the reporting for what we're used to. And then screening for COVID-19. So during the pandemic, a screening code is generally not appropriate. And I put the emphasis on the coding guidance will be updated as new information concerning any changes in the pandemic status becomes available. Because with the updates that they're thinking about giving for 2021, will change this information. All right, so asymptomatic individuals who test positive, you'd follow your other guidelines. So even though they're asymptomatic, they have tested positive and they are considered to have the COVID-19 infection. So you'd use the Use 07.1. And then personal history. Right now they're saying assign code Z86.19. And so this is some of the information that may change with the code updates. So for follow-up visits, after COVID-19 infection is resolved, you do have the information. You can assign a code Z09 within that range. All right, so what about antibody testing? So they've said, if you have a patient that's coming in for antibody testing, and you can assign the Z01.84, but if they're being seen to confirm a current COVID-19 infection, you would go through and read the other guidelines. So they're pointing you to the other guidelines where you can take a look to point you in the right spot for coding. All right, now during the September 8th, the ICD-10 Coordination and Maintenance Committee meeting was September 8th and 9th. They finally got the recordings posted, but on the second day, they did propose some new codes for COVID-19 related issues. They are trying very hard to get them eligible for use on January 1st of 2021. They're not sure if they're going to make it, but so they may have a January 15th start date. They just didn't have anything in stone yet. But they've proposed codes for a multi-system inflammatory syndrome. And that's going to be in the M35.8 rubric, which is connective tissue syndromes. It's also known as your pediatric inflammatory multisystem syndrome. And they had a slide that that listed a bunch of the items that are part of this syndrome. It's, endocarditis. They're also finding neurological impairments. It's very similar to Kawasaki's disease, so there may be some changes there. And while it mainly has been affecting pediatrics or children, they are also finding adults that have this syndrome as well. So they're not restricting it to a specific age. And so they can, so they are proposing this to be able to use. And then they are also submitting a code for pneumonia due to coronavirus disease 2019 in the J12.82 area. And then, of course, there'd be instructions that would come out for this. So they are also proposing the Z11.52, which is an encounter for screening for COVID-19. And this would be used for asymptomatic patients. Otherwise, you would use the signs and symptoms, like cough, fever, those kinds of things. So, and so I put a note in here that may cause a change to the guideline regarding the screening during a pandemic. And then they're proposing the Z20.822 for contact with and suspected exposure to COVID-19. And then the Z86.16 for a personal history of COVID-19. And then one of the comments that was made was, would they be creating a code that is like for observation for exposure ruled out? And so that was not answered, but it was something that was brought up. So I thought it was good because it was proposed by a doctor that was also saying, oh, well, this kind of sounds like what we did for anthrax. And so she was asking if there would be that, the observation for exposure ruled out. And so I just wanted to throw that one out there too, so we don't get all surprised. And this one I thought was funny because your medical alert bracelet really brings out the blue in your overalls. All right, so some of the topics that were in the proposed rule that were related to the COVID-19 waivers was regarding the Hicks code C9803. And the intent with the C9803 was to just keep it during the public health emergency and then delete it and extend that usage of the code. And they were asking, should we just go ahead and extend the usage of the code, through the end of the year that the public health emergency is, or should we make it permanent? And so for me, it raised the possibility that the public health emergency would carry into 2021, and that now has been confirmed it will. So we'll need to keep an eye on that. And then also the non-surgical extended duration therapeutic services, the supervision for that was proposed to change that to general supervision for the entire service. And that was, keeping the, the social distancing. Comments were due by October 5th. And then in the Medicare physician fee schedule arena, they wanted to create additional categories of services for telehealth services, but this really was only for professional services. It did not extend into any facility services. And then they were also proposing to change the direct supervision to permit audio-visual presence, and also to allow supervision of diagnostic procedures, to allow providers to practice at the top of their license. So that would be allowing like advanced registered nurse practitioners to supervise diagnostic procedures. And then they're also proposing that for teaching facilities that the direct supervision be by the audio-visual presence, and then to continue to allow residents to moonlight in the inpatient setting. All right, and I think I got to the end of my slides. And Tally, if you're available.
Yes, thank you, Ardith. That was fantastic. We will now begin the Q&A portion of the event. Please continue to type your questions into the Q&A panel if you have not already, and we will be answering the questions as they came in and as time permits. So we will work to get questions answered right now, and assuming we cannot get to everything today, our team will be working on some additional documentation that we will have up on our website in the days following. So why don't we jump right into things, Ardith? Dense topics, so lots of questions. I'll start from the top. So please clarify on the PCS codes effective on 8/1 as per PCS file, or on discharge of 8/1 or after, and then a follow-up comment that we're seeing these used in discharges of 8/1 and after, even if the infusion was given closer to admission dates in July.
Okay, well, there it's generally for it is for this, well, it's usually for discharges after 8/1, but I can go in and double check to make sure that it's, even if it's the date of service is in July, because I know it's somewhere, it's in the it's UHS, the I know the acronym and I can't remember what what it stands for. It's like the UHDHHS data set. But it's in the CM guideline or the coding guidelines, and I can go find that and send that out to you so that we know for positive. But that's a very good question.
Okay, next question. If a patient is receiving telehealth services from a HOPD from two different MDs within the same practice who do not have the same specialty, the MDs are permitted to bill two separate E&M codes. Based on this scenario, would the facility be able to bill 2 units of Q3014?
No, I think they are still restricted to only being able to use that for 1 unit of service. Because I would have to go and double check the medically unlikely values. But if it's 1 connection, it would be 1 unit of service. But if they're kind of the one has the call and then later the other one has the call, then you should, because it would be like 2 separate visits.
Okay, another that came in relatively early on in the presentation, what are the reimbursement rates for the new codes?
Gosh, I wish I knew which codes those were. If that is for the lab codes, those have not been published. And what CMS has been saying on those is that they are to be locally priced by your medical, like by your Medicare administrative contractor, because they don't have any pricing information. So they have to go through that laboratory test annual review process. So it may not be until, and that doesn't take place until June or July in that time frame. So we probably won't have any specific pricing on those for probably another year.
Okay. All right, next question. For hospital outpatient clinic visit for specimen collection for COVID testing, Does this still apply for PLA code 0241U, even though it contains other viruses that are not COVID?
Yes, you are able to use that. And the reason why they allow that is because there are so many similarities that you're trying to figure out which one do they have, or do they have multiple. So while they haven't specifically said anything on the 0241U, it's kind of the general guiding principle for those.
Okay. My facility is a RHC. My providers have been doing a combination of telehealth and face-to-face visits with their patients. Do we need to bill the Q3014 instead of an E&M for our telehealth visits? And there's a couple other questions on Q3014 coming up as well, Artie.
Okay, yeah. For rural health clinics, I don't believe you're eligible for the Q3014. I would have to double check on that one, because then I'm trying to remember if the G0227 was specimen collection. I'm sorry, some of the codes are starting to get fuzzy and run into each other these days.
Okay.
But did I address that? Because what I'll need to look that one up, because I haven't studied as hard on the rural health clinic stuff because I've focused more on the OPPS facility stuff.
Okay. Continuing on the Q3014 questions, how can facilities truly justify reporting the Hicks picks when facility costs and resources are minimal or negligible at most?
Well, if the facility, if your costs are negligible, then report the Q3014. But if your facility staff is providing the service, if it's like the Coumadin clinics, and the physician may not be involved, then for those services, definitely you would want to bill for your for the higher level service and get reimbursed for those. But so basically, if it is just supporting the professional service, then the Q3014 is the way to go. But if you are doing much more than that, then make sure you're recovering your costs. Because there are some telehealth services that are charging. I think I heard one place say they were getting charged, it was 75 cents a minute for that service, and so that was being incurred by the facility, and so that would give you a way to recover those types of costs.
Okay, and then another question on Q3014, does it have to be charged on the same day that the physician charges? The example they give is a 99441. Our nurses are call the patient and do an evaluation a day prior to the physician's call.
Oh, that is a good question. I have not heard that one yet. So you have done a good one and stumped the trainer. Yeah, if they're calling the day before, I would say, you would need to report it on the date of service when the service was provided, which is the kind of the general guidance for date of service reporting.
Okay, and then the next question is asking for some clarification. So to validate if the hospital is going to bill the Q3114 facility origination fee, There is, in an instance where you do not need to provide the patient list with the home addresses to CMS.
Then to report the Q3014, you have your distant site provider, which is where the physician is located, and then you have to have like the originating site, and that's where the patient's at. Well, if the patient comes into your facility and you talk to another physician, via telehealth in 5 counties over, then that would be the Q3014. If the patient is at home, because it is not it's not allowed to be an originating site, then you're not able to bill the Q3014. And so that's why they have that whole rigmarole process where you would have to have the patient's home set up as a provider-based apartment.
And this looks to be, this next question is on a similar thread for PT, ST, OT. Why wouldn't the patient's home be considered a PBD?
And that's because by law, the patient's home cannot be a provider-based apartment. And so in that instance, you're not able to provide it with the Q3014.
Okay, it looks like we've got time for 1 or 2 more here. So the next question, Ardith, is what is the COVID testing is being done at an outpatient clinic as a drive-through, but the patient has an office visit that same day elsewhere? Can the 99211 be charged for the collection of the swab?
It could be. Now, so if they're done at different times, in different locations, then yes, you would bill them separately. There's in the references on the AMA site, they have I gave the link to their coding and guidance site, so that has the access to the CPT Assistant Special Edition articles. But down near the bottom, they have some coding scenarios, and they address that and kind of point you to which codes would be appropriate. So if you're billing for a clinic visit, then you could do the 99211 for the collection, or if it's a hospital outpatient department, you could do the C9803. But since they're at different times, then they would be reported separately from the evaluation and management code that's done by the physician.
Okay, and I think this will be our last question that we'll have time for on the line here today. Do you have any documents that show we can bill 99211 with a COVID test in the clinic and get around the Incident 2 regulations?
That is well, I guess the assumption is that if you're doing the collection that there is a physician there on site, and actually for the guidance for the supervision, they have waived that so that the provider needs they can be by audio-visual presence. So if they're available by doing FaceTime, well, not FaceTime, that's not one of them. So if you have like Skype or some type of private channel where you can contact the supervisor if you have an issue, that is one of the flexibilities that's allowed under the Public Health Emergency Declaration.
Okay, well, unfortunately, we are out of time as far as being able to answer the rest of the questions. I know Ardith and team will be reviewing all the questions that were posed today, both those that we got to and those that we did not. And in the days ahead, we will work on getting some additional documentation up on our website and sharing that out as widely as possible. So please check back for some additional documentation when it comes available. So with that, thank you, everyone. We hope you enjoyed the session and found it informative. And as I mentioned earlier, we'll be posting a recording of today's presentation as well as a copy of Ardit's deck to the webinar page on vitalware.com later this afternoon. We'll be emailing you that link once it's ready a few hours from now. That email will also contain your CEU information, so be on the lookout for it. If you'd like more information on anything you saw today, please reach out to your VitalWare account manager, or you can come to our website and chat directly with us or schedule a demo. And you can also follow us on LinkedIn and Facebook to stay informed of future webinars and to catch our latest and greatest content. So thank you all again for joining, and have a great day. And thank you, Ardit.
All right. Thanks, everybody. Bye.